Module 8, Oxygenation. So we're going to start with the definition of oxygenation. So per your textbook, oxygenation refers to how well cells, tissues, and organs of the body are supplied with oxygen. And the main concepts or processes that we'll be discussing are respiration and ventilation. To understand oxygenation, we need to quickly review our pulmonary system. So if you look at this picture here, you can see that above our trachea is considered our upper airway, and below our trachea is considered our lower airway. So when we breathe in, air goes through our nasal cavity, which helps to humidify the air. It goes down through the trachea, through our bronchioles, into our lungs, where the oxygen can be transported into the bloodstream. Okay, so part of our pulmonary system are airways and lungs. Then we have ventilation and respiration. So when we talk about respiration, we are not talking about what we count during vital signs. So ventilation, we'll start with ventilation, is the movement of air in and out of the lungs when you breathe. Okay, so if you take a big deep breath in and then you exhale it, that is ventilation, just the movement of air in and out of the lungs. Respiration is referring to gas exchange. So when we breathe the air in, it has oxygen in it, which then will participate in gas exchange at the alveoli level. Okay, so again, during this module, when you see the word respiration, we are talking about gas exchange at the alveoli and capillary level. Ventilation is just the movement of air in and out of the lungs. So technically, when you take vital signs, you're counting ventilations. Okay. So now let's go over what alveoli are. So alveoli, they are sometimes described looking like little bunches of grapes. They're round and they're filled with air. So they're tiny air sacs and they're surrounded by capillaries, which means it's very vascular. Capillaries are just little tiny blood vessels. So at the site where these capillaries meet these alveoli is where gas exchange happens. Oxygen comes in from the air we breathe, and then carbon dioxide goes out with each exhale. So carbon dioxide is the end product of metabolism. So as you remember from our nutrition lecture, our body is constantly using energy. Our metabolism just at rest, we're always using energy in our body to breathe, to digest, to think, and that results in carbon dioxide. Okay, so that's a byproduct of metabolism. So the carbon dioxide is brought to the lungs via these capillaries, and when we breathe in, the oxygen is brought in by the air, and then there's an exchange, a gas exchange. So oxygen can come back into the body and carbon dioxide can leave the body. This is also part of our acid-base balance. Okay, breathing is part of our acid-base balance. So there are two types of alveolar cells. We don't really need to know the specifics of those, but I'll just go over them briefly. So type 1 are the gas exchange cells. That's pretty much their job. Type 2 alveolar cells produce surfactant. Okay, this is a lipoprotein that helps those alveoli to expand when we're breathing. So when we take in a breath of air, those alveoli air sacs inflate and deflate. Okay, so that is the normal process, and that needs to happen effectively in order for gas exchange to occur. So now we're going to go over factors that affect ventilation. And again, ventilation is just us breathing in and us exhaling out. So the first thing here is the rate. So your rate of ventilation. So if you're breathing really fast or you're breathing really slow, that is going to affect how much oxygen and carbon dioxide is in your blood. The depth of your ventilation. So if you take really deep breaths, and on the other side, if you take very shallow breaths, that can affect how the levels of carbon dioxide and oxygen levels in your blood. Then we have lung compliance. So normally our lungs inflate pretty easily. Okay, so compliance refers to how easy it is for our lungs to inflate. So lung compliance would be reduced by edema. So if you have fluid in the lungs, if you have loss of surfactant, remember that's what those type 2 alveoli cells produce, surfactant. It helps those alveoli sacs to inflate, or if the patient has some type of condition that causes the elastin fibers in the lungs to be impaired. So like if there's scar tissue in the lungs, that is going to impair lung compliance. Then we have lung elasticity. So lung elasticity refers to the ability of the lung to recoil. So the lungs are kind of like a rubber band. So if you stretch it out, they should return back to their normal structure. Okay, so elastic recoil is lung elasticity. So some conditions will have loss of elasticity in the lungs. So if the lungs inflate, they have a really hard time deflating. Okay, so for example, emphysema, the lungs are overstretched and they lose their elastic recoil over time. So what happens is the alveoli fail to deflate completely and there's air trapped in there. So all of these things interfere with gas exchange also. Then we have airway resistance. So airway resistance is referring to the air that passes through our airways, so our trachea, our bronchioles. The larger the diameter of the airway, the better the air moves through it. So if you have constricted bronchioles, then you are going to have decreased airway resistance. So we just explained ventilation, so now let's talk about respiration. So again, respiration is gas exchange, and this is happening at the alveoli level. So there are two types of respiration, external and internal. So external is actually happening at the alveolar capillary membrane. And some things that can impair this would be pleural effusion, which is fluid in the lungs, pneumothorax, which is when one of the lungs collapses, and asthma can also cause impairment of the external respiration process. Internal respiration occurs at organs and tissues where they receive the oxygen there. So external is when the air is externally coming in through the lungs, meets the alveoli and the capillary, and they have that exchange. Internal respiration is when the oxygen is already being carried through the vessels, and now we're at the organs and tissues, and the oxygen is being passed on to them so that they can use that for metabolism. Okay, so that's the difference between internal and external respiration, aka gas exchange. So now let's talk about how our breathing is controlled. So the respiratory centers in our brain control breathing using feedback from chemoreceptors and lung receptors. However, we do have some voluntary control of our breathing, and it can override that respiratory center in our brain temporarily. So for example, you can hold your breath. You can do activities while you're still breathing, like swallowing, whistling, stuff like that. So that is you making a conscious effort to control your breathing. You can also increase your respiratory rate. You can decrease it. You can take a shallow breath, a big deep breath, so that kind of thing. Okay, so what are chemoreceptors? So chemoreceptors are located in the medulla of the brainstem, carotid arteries, and the aorta. And they are constantly monitoring the blood that's passing by them, and they detect changes in our blood pH, our oxygen, and our carbon dioxide levels. When they feel that something is off, they're going to send a message to our respiratory center in the brainstem, and then that respiratory center is going to either decrease ventilation or increase ventilation so that they can maintain those normal levels of pH, oxygen, and carbon dioxide. Then we have lung receptors. So these, just as the name implies, they're in the lung and in the chest wall. And they kind of are sensitive to our breathing patterns, lung expansion, lung compliance, we talked about that, airway resistance, and respiratory irritants. So if you're walking by a building and there's all this smoke, or you inhale some dust, those little lung receptors are going to send a message to the respiratory center in the brain to adjust the way we're ventilating or the way that we're breathing. And just one note to remember, you cannot measure gas exchange by counting breaths per minute. So if you're breathing really fast or really slow, there is no way to really tell how much gas exchange is happening at the alveoli level. Okay, so you can't measure that by counting breaths. You need another way of measuring, which we're going to talk about. Okay, really important here is, what is our primary stimulus to breathe? So in a normal, healthy person, high levels of carbon dioxide is what stimulates breathing. So high levels of carbon dioxide is toxic to us. It's a byproduct of metabolism. We need to excrete it. Our body knows it's get it out. And the way we get it out is by exhaling. So if you take a big breath, you hold it, you're holding it until you can no longer hold it, you're going to have to breathe. And that message that's forcing you to breathe is your brain calculating how much carbon dioxide we have. It's building up. You need to breathe to let it out. Again, the primary stimulus to breathe in a normal, healthy person is high levels of carbon dioxide. A secondary stimulus would be low levels of oxygen. Now, you don't really need to know that because you just need to know the primary stimulus to breathe. However, in COPD, chronic obstructive pulmonary disease, COPD, this is a chronic condition. Their drive to breathe is low oxygen levels. Okay, over time, you'll learn all about it in Med-Surg, but for COPD patients, they retain carbon dioxide, and over time, their body kind of adapts and kind of gets used to higher levels of carbon dioxide. So their drive to breathe is no longer those high levels of carbon dioxide. It's kind of the opposite. It's low levels of oxygen. So what this means for you as the nurse is, if you have a patient that comes in with COPD, you have to be really careful with how much oxygen you give them, because that can actually stop their breathing. So with these patients, you always want to know what their baseline is, their baseline oxygenation saturation. So if they come in, you ask them, oh, so what do you usually set at? They may say 88%, they may say 89%, and that's perfectly fine. They may have that reading on room air, or they might even be getting oxygen and they're still 88 or 89%. Again, that's perfectly fine for them. So say you have a patient that comes into the hospital and they have pneumonia. They also have history of COPD. When they come in, if their saturation is an 85%, yes, you want to give them maybe 1, 2, or 3 liters of oxygen. However, you have to be really careful to give them any more than that, because they could stop breathing. So again, it's really important that you assess your patient, you know what their history is, because you can't just give people oxygen without knowing more information because of those type of patients. Before I go into factors that influence pulmonary function, I want to just mention how important the relationship is between the heart and the lungs. So the heart has to have adequate circulation, has to provide adequate circulation in order for there to be adequate gas exchange between the alveoli sacs and the capillaries. So if you have a weakened heart that isn't pumping strong enough or adequately enough, then circulation isn't going to be optimal, and the blood, those red blood cells that are going to the lungs to have that gas exchange, may not be there. So maybe we're breathing in enough oxygen, but is there enough red blood cells in circulation to actually pick it up and take it to the rest of the body? Okay, so just remember that the heart and lungs go hand in hand. So if you have a patient with a heart problem, it can affect their gas exchange. Okay, so continuing on to factors that influence pulmonary function. So we have lifespan and development. So as an infant, your lungs are immature, they're still growing. So infants can be really sensitive to infection, which can influence pulmonary function. The environment. So if you're stressed out, stress in general suppresses the immune system, and it can cause it leaves you open for infections, so you can get more respiratory infections. Allergies, so there are pulmonary allergens in the environment, and lots of people have them. Dust mites, pollen, molds, cigarette smoke, animal dander, all kinds of things can affect your lungs. Lifestyle. So let's see where you live. Like for example, if you live on a very, very high altitude, or if you go mountain climbing, the higher you go up in the atmosphere, the less oxygen will be available. So that can cause hypoxemia and hypoxia. Hypoxemia is low levels of oxygen in the blood, and hypoxia is low level of oxygen in your tissues. When you're pregnant, that can change your pulmonary needs. A lot of times pregnancy leads to anemia, and there's less red blood cells to carry oxygen. Occupational exposure to hazards. So if you work somewhere where you're exposed to chemicals, maybe you breathe them in, that can cause issues with breathing. Smoking tobacco or e-cigarettes, we know that that's bad. That can definitely cause damage to your lungs. So you're going to hear how important smoking cessation is. That's because smoking constricts those bronchioles, and it increases fluid secretion into the airways, which causes inflammation, swelling of the bronchial lining, and it can paralyze the cilia. That's all major damage to the lungs. So we really, really want to educate our patients not to smoke or to stop smoking. Then we have medications. So there are many medications that affect our breathing. For example, respiratory depressants depress our central nervous system, and it can weaken the muscles of breathing. So for example, morphine. We know morphine, we have to do a really good respiratory assessment before and after to make sure that our patients are safe. So continuing on with factors that influence pulmonary function, so we have upper respiratory infections, referred to as URIs. So upper respiratory infections are any infection in the sinuses, the throat, airways, or the lungs. So that's all considered upper respiratory infections. And that is a lot, accounts for a lot of the reasons why people go to see their doctor because of an upper respiratory infection. Let's see, and the most common one would be the common cold. Then we have lower respiratory infections. So this includes acute bronchitis, pneumonia, and tuberculosis. Okay, moving on, pulmonary system abnormalities. So there can be structural abnormalities, airway inflammation, obstruction, alveolar capillary membrane disorders. All of those things are going to impair our lung function. Pulmonary circulation, central nervous system. Whenever you hear central nervous system, it's going to be our brain involved, like maybe a trauma or a stroke can affect the breathing. Spinal cord injuries, depending on what level of the spine was injured. If it's very high up in the cervical spine, you can lose your ability to control breathing. Those patients would need to be on a ventilator. So now we're going to talk about assessing patients with respiratory concerns. So really important concept, what you ask a patient in what order you ask them is really going to be determined by the situation. So if they're in an obvious respiratory distress, then you are going to ask them simple questions about what's going on right now. You don't want to ask them, these questions that are open-ended, that's, makes them have to talk a lot to get the response. You want closed questions so that they can say yes or no. And you really want to focus on your ABCs for somebody who is in obvious respiratory distress. If you have a healthy person, then you do want to ask them your full assessment to find out if they have any of those risk factors that can impair pulmonary function, like do they smoke, where do they work, what kind of medical history they have, etc. And then for a complete focus respiratory assessment, you're going to need to identify all of those things, perform a physical exam, and also maybe even refer them to have some diagnostic testing. Moving on to your physical examination of the pulmonary system. So this might be a review for you from health assessment, and in a few more slides there's even more detail that we're going to go over, but this is just a nice little overview. So inspect, palpate, percuss, auscultate. So inspection, you're going to observe respiratory patterns, you're going to look for signs of respiratory distress, you're going to look at the chest structures and movement, you're also going to inspect the skin, mucous membranes, the color, if the patient has edema. You're going to assess the sputum, note the characteristics, and overall general appearance of the patient. Okay, so that is number one. You're going to inspect. Then we're going to palpate. So palpate, you're going to check skin temperature and see if there's any areas of redness. Again, this should be review for you guys. Percussing. So percussing would be over the lung fields and you're looking for consolidation or excess air pockets. And then of course you want to auscultate breath sounds and vascular sounds. And I know you're going over that actually right now in health assessment. Okay, you also want to assess breathing patterns, and we're going to go over each of these terms later. Eupnea, tachypnea, bradypnea, apnea, Kussmaul breathings, Biot reading, and Cheyne-Stokes respirations. You want to assess for cough because you can either have a productive cough or a non-productive cough, and that makes a difference. So you want to ask that, and we're going to talk a little bit about that later too. You want to ask questions like, have they had a fever? Do they have chest congestion, nasal discharge, watery eyes, stuff like that. You want to ask about dyspnea, chest tightness and wheezing. If they do have a productive cough, then you may need to obtain a specimen for culture. Okay, so there's a lot of things to think about when you are assessing the pulmonary system. So now we're going to go into a little more depth of each kind of area that we use to assess a patient's pulmonary system. So here we have breathing pattern. So you should become familiar with these terms: eupnea, tachypnea, bradypnea, apnea, Kussmaul's breathing, Biot's breathing, and Cheyne-Stokes respirations. So there are others, but this is what your textbook lists, so this is what we're going to go over. So this little box here with all the colors, it gives you kind of like a nice little picture. So eupnea is normal breathing. So you see our breathing should have that squiggly line, and that's kind of depicting breathing in, breathing out, breathing in, breathing out. Then we have tachypnea. So tachypnea is just an increased respiratory rate. And you should definitely be familiar or memorize what is considered a high respiratory rate. So this is going to be more than 24 breaths per minute. Okay, tachypnea is fast, shallow breathing, more than 24 beats per minute, 24 breaths per minute. Then we have bradypnea. So this is like the opposite of tachypnea. This is going to be slow respiration, so fewer than 10 breaths per minute. Okay, and this definitely can cause poor gas exchange. And this can be a result of medications, like I mentioned before, like sedatives or opioids, or any kind of like muscle relaxers. Okay, then we have apnea. So this is absence of breathing, and it can be intermittent, so like you can have episodes of apnea. Kussmaul breathing. So this is increase in rate, so you're breathing pretty fast, and an abnormally deep respiration. So breathing fast, but the respirations are deep. This can happen for a few different reasons. Sometimes if you are acidotic, so your pH levels are low in the blood, your body will try to breathe off oxygen, carbon dioxide, because carbon dioxide is acidic. So if you have Kussmaul's breathing, it could be that you're acidotic. Then we have Biot's respiration. This is irregular respiration, but it's variable in depth, so it doesn't necessarily have to be deep or shallow. It can be either or, a combination of the two. And there's alternating episodes of apnea. This one is usually caused by damage to the brain. So this is the central nervous system, maybe as a result of some type of brain injury. The next one is Cheyne-Stokes respirations. So this is a gradual increase in depth of respiration, followed by a gradual decrease in depth, and then a period of apnea. This happens, again, brain injury, and also at end of life, sometimes that can happen. Okay, so those are your main breathing patterns. Next is respiratory effort. So this one, you're looking at the patient and you're going to document their respiratory effort. Nasal flaring. So this is when you can actually see the nostrils become enlarged with every inhalation. And the body is doing this because it helps to reduce the resistance of that airflow in the nose, and it helps to keep those nasal passages open so that the patient can take in more air. So you may see nasal flaring. Retractions. This is when you look at the chest and you can see the intercostal muscles kind of pulling in. So that's not a normal direction they pull in. And I have a video of that you can watch so you can see that. That's common in kids. Okay, use of accessory muscles. So again, it's easier to show this on a video, but we have these accessory muscles that help with breathing, but they're not the primary muscles. So during respiratory distress, you can actually see those accessory muscles being used, and we can document it that way too. Grunting. This is like noisy, difficult breathing. It's caused by forced expiration. So you're exhaling against a closed glottis. Okay, it's caused by involuntary muscle contraction during expiration, and it actually helps to keep the alveoli open and enhance gas exchange. So it's something that your body just does, okay, which is kind of cool. Body positioning. So if you ever have a patient that says, I can't lay down, I can breathe better like this, like the picture shows here, kind of hunched over, then that can be something that you document as increased respiratory effort, and you can describe the way the patient is sitting. Paroxysmal nocturnal dyspnea. So this is when you wake up and then, all of a sudden and you're short of breath. So it's something that happens during sleep, and this can cause the patients to have anxiety, feel kind of panicked, and sometimes the patient needs to sit up really quick in order to ease that shortness of breath. Conversational dyspnea. This is when you're not able to talk without becoming short of breath. So a lot of times if a patient has COPD or emphysema and they're having an exacerbation of that, like maybe they got sick on top of that, sometimes it's hard to talk to them because it's so difficult to talk and breathe at the same time. So that would mean they have conversational dyspnea, and you can chart it that way, document it that way. Stridor. I know you guys are familiar with this term, but it's like a high-pitched sound that happens when you inhale, and it's caused by partial obstruction of the larynx or trachea, and you don't need a stethoscope to hear that. Most of the time you can just hear it. That is usually a medical emergency because a partial airway obstruction can easily become a complete airway obstruction, so you don't want to wait if you hear stridor. Wheezing. Wheezing is something you'll see in asthma patients. It's described as like a musical sound, and sometimes you don't need a stethoscope to hear that either. And then diminished or absent breath sounds. So in a patient that has dyspnea, again, dyspnea is like shortness of breath, if you have diminished breath sounds, it can mean that ventilation is becoming worse, is worsening, and the patient's not oxygenating. So if a patient's very short of breath and you put your stethoscope on them and you can't hear breath sounds, or they're very, very diminished, then that's not good, because they're not moving air, they're not ventilating, which can lead to a medical emergency. Pulse oximetry. Okay, so I think everybody has seen a pulse oximeter. This is a non-invasive way to estimate the arterial blood oxygen saturation, which is SaO2. So this is the percentage of hemoglobin molecules that are carrying oxygen. We will document this as SpO2 because that is a measurement when we use a pulse ox. So when you are documenting this, you're going to say SpO2 with the percent. So a normal value for pulse ox is going to be 95 to 100. If you're a healthy person, if you have a pulse ox less than 94%, then that is considered abnormal. So you should look further, assess further, ask more questions. One thing you should remember is that the pulse oximetry has a light in it, and that light should be on the nail bed. So there's a certain way to put on the pulse ox, and it's actually measuring the light absorption by the hemoglobin in your blood. So you can imagine when you are using this probe, there has to be a pretty good contact. So like acrylic nails or dirty fingers, you may need to take off the nail polish or clean the hands just to make sure that that light is penetrating that nail bed appropriately. So this slide talks more about pulse ox, and this is straight from ATI. I pretty much screenshotted it here because I liked all the content, straight into the point. So oftentimes you'll get a test question, or maybe in real life you have a pulse, you're putting the pulse ox on the patient and it's showing a really low value. Before you freak out, before you start documenting or reporting things, you want to troubleshoot it. You want to make sure that it's on correctly. You want to make sure that the patient's hands are clean. You want to make sure that there's circulation, that their hands are warm, before you document any abnormal reading. Okay, and know like all of those things I just mentioned affect it. So like if the patient has hypothermia, so they're really cold, or if they just don't have really good blood flow to their extremities, then that might affect the pulse ox functioning. Okay, so keep that in mind. So this is from your Davis textbook. Again, screenshot. Again, I would encourage you just to kind of skim through this, some of the things I just talked about. Okay, moving on to cough. So coughing is part of our respiratory assessment. So if a patient is reporting that they are coughing or you see them cough, you want to ask them, is it dry, productive, or hacking? So a productive cough means that they are making sputum, and sputum is a combination of like mucus and debris coming up from the airways. Okay, so sputum is coming up from the airways, and we call that a productive cough. So some questions you want to ask a patient would be, when do you cough? How long have you been coughing? What makes it worse? Does anything help it? What have you been using to treat the cough? And did that help? Sometimes allergies can be associated with cough, nasal congestion, sneezing, watering eyes, and a lot of times just over-the-counter medications can help with this. An upper respiratory infection, or URI, if they have a cough, it will usually be in combination with the fever, chest congestion, noisy breath sounds, and sputum production. So if they have those things, most likely it's going to be an upper respiratory infection, and those need antibiotics. Airway obstruction and constriction. So if you have a cough that's associated with dyspnea or shortness of breath, chest tightness, and wheezing, this can be related to an airway obstruction like asthma. So those patients may need different medications like corticosteroids, which reduce inflammation, or bronchodilators, which dilate all of those airways to, make sure that oxygenation is happening. Now, if a patient has a productive cough, then you're going to want to note the appearance, if there's an odor, the amount, and the timing. Like, is it more in the morning? Is it more at night? Or is it like all day long? And usually we're going to want to get a sputum sample. Okay, continuing on with how we assess the oxygenation status. So we have diagnostic testing. We can take a sputum sample and culture it to see if any kind of bacteria grow. We can do skin testing, and specifically tuberculin skin testing. Pulse ox, we talked about. Capnography, that is typically done on patients who are intubated. They can also be done on patients who have like a special type of nasal cannula, but these are measuring carbon dioxide levels, exhalation when you exhale, to see if it's normal. Spirometry is this picture here on the top. So a patient has this little machine, blows into it, and then the machine will record volume levels. ABGs we're going to talk about on the next slide, and then we have peak flow monitoring. That is pictured here in this bottom left. Little meter you blow out, and it kind of measures how much your capacity is. Okay, we can also assess ABGs. Now, we're not going to go into ABGs too much in this term, so this is just a little introduction, but we do use ABGs to assess our oxygenation status. So the way you get an ABG sample is you get a syringe with a needle like in the picture, you palpate for the pulse, usually it's the radial or brachial pulse, and then you take a sample directly from that artery. Now, in most hospitals, this is actually done by the respiratory therapist. However, RNs, it is in our scope of practice. So especially if you work in ICU, you may be the ones obtaining the APG specimen. So this is an arterial blood gas, and they are measuring that blood for our pH level, our oxygen level, and our carbon dioxide level. So when you refer to an ABG value, you're going to say PO2 and PCO2. That is referring to partial pressure of oxygen and partial pressure of carbon dioxide. You can read about this more in your textbook, but that basically means that's the levels inside an artery versus a vein. This is a table from your Davis textbook. I liked it because it's really simple, so you can kind of just skim over this. It just shows some other tests, some labs and other diagnostic testing that we can check for oxygenation. All right, so our nursing diagnoses for patients that have respiratory issues. Here are some examples: airway clearance impairment, breathing pattern impairment, gas exchange impairment, spontaneous ventilation impairment, and so on. So interventions for optimal oxygenation. So we can give medications, we can use a mechanical ventilator, and we can use chest tubes. So respiratory medications are prescription, of course, so we're going to follow doctor's orders. Mechanical ventilator is when the patient is unable to breathe on their own safely for whatever reason. We're going to have a machine do it for them. Use of chest tube drainage systems. This is when a tube is inserted into the lung and it is removing either fluid or air. It could be fluid like pleural fluid, it can be blood, or it can be air. So these are all things that you should be familiar with because it's what we can do to help our patients have optimal oxygenation. So prevention, we want to make sure they're getting their immunizations, so their pneumonia vaccine, their flu vaccine, their COVID vaccine, so that they don't end up in the hospital in the first place. We want them to stop smoking because smoking can damage their lungs and make them more susceptible for infection and impaired breathing. Positioning, we want to be aware that certain positions can help, and we're going to talk about all this later, can help a patient breathe better. Incentive spirometry. So in this picture is an incentive spirometer, and you will need to know how to explain and demonstrate how a patient should use this. So this is often used when a patient has just come out of surgery and they need to exercise their lungs. So when you grab one of these and you put your mouth there on that mouthpiece, instinctively you try to blow into it. But this is actually an exercise for your inhalation. So you want to ask the patient to take a breath out, to breathe out all the way they can, and then to take a big deep breath in with their mouth on here. And once they reach their maximum capacity, they should try to hold it for 3 seconds and then slowly let it out. If you look, there's measurements here and a little slider, a little yellow slider. So you slide that up to the patient's goal. So first you see how high they can go, you mark it, and then you have them keep doing this like every hour while they're awake. And it's really encouraging the lungs to inflate and then recoil back down. So it can kind of prevent lung collapse. It can help those alveoli sacs inflate and deflate. So this is really important. So if you ever are writing a care plan or one of those concept maps for anyone who has a respiratory issue, you can always suggest this. Encourage patient to use incentive spirometer. All right. Okay, interventions for optimal oxygenation, continuing on. Mobilizing secretions. So we know that immobile patients, horizontal in bed, will have pooling of secretions. If a patient is in bed and they're not immobile, but they have maybe a pneumonia, some type of infection, inflammation, those secretions are going to build up. So by coughing, turning, deep breathing, that can help deep inhalation. It promotes really deep inhalation and forces expulsion of those secretions. Okay, so it's really important that we educate our patients to do that. Hydration, so systemic hydration, meaning maybe IV fluids, humidified air, nebulized air. So these things will help coughing. It will kind of enhance coughing. It will mobilize secretions. It will thin them out, break it up. and help to expel them. Chest physiotherapy includes chest percussion, vibration, and postural drainage. So these are things that you can do at the bedside, like chest percussion. That's when we kind of pound on the chest and it kind of breaks up those secretions. Vibration, that's like a vest that is put on the patients and it literally vibrates. And then postural drainage. So depending on where the patient has the secretions building up, you can put them in a position where gravity kind of helps to drain those lungs. Then we have oxygen therapy that we're going to talk all about later. Artificial airway. So the thing to remember with this is that if you have an artificial airway, we need to maintain patency of that airway. So we will have to suction as needed. One thing to keep in mind though, when you have a little tube, a catheter, suction catheter that's hooked up to suction, you're not only removing secretions, you'll be removing air from the lungs too at the same time. So you want to make sure that you are giving the patient oxygen before you do that, during and after. And also you should not be suctioning on a routine schedule. You only need to suction as needed. Sure, the patient may need it every hour, then you do it, but you're not going to go in and say, okay, it's time for your suctioning, it's been 2 hours. Remember, each time you put the catheter down the airway and you suction out, you can be irritating the mucous membranes. Sometimes that catheter kind of sticks to the lung tissue and you can actually injure that tissue. So if we don't have to do it, we're not going to do it. We're only going to do it when needed. So here we have a picture of artificial airways. We have the oropharyngeal and nasopharyngeal airways, and you can see by the picture how it's placed and what they look like. So some of you may have seen these if you, some of the CPR classes, the BLS classes will show you the airways. And if you notice, these are not going into the trachea. They are just in the pharyngeal area. So the reason you put these in is just to secure an open airway so that you can bag the patient. And an ambu bag is here pictured on the right. So this will allow the air to move freely. Like say example, it helps protect it from the tongue. If you have weak muscles back there and the airway is closed, this will open the airway and will allow you to ventilate with the ambu bag. Then we have endotracheal tubes and tracheostomy tubes. So you can see here, these go all the way down to the trachea, big difference. And this one, you can either hook up to a ventilator or you can also use the ambu bag, okay? So next we're going to talk about how to collect a sputum specimen. So there are 2 ways to do it. The first way is called an expectorated specimen. That means the patient is actually able to bring it up and spit it out themselves. So first thing you're going to do is to check the order, and we want to have the patient in good position, so either high or semi-Fowlers or sitting up in bed. They can be dangling on the side of the bed, just depends on the patient. You want to protect the patient with a towel if necessary, if you think it's going to get messy. And here's the important part. You want the patient to take a deep breath and then to cough to expectorate secretions. Really important, saliva is not sputum. Sputum comes from the airways. Okay, so we really want to get that thick, that thick phlegm to come up and out. So if you look here, we have sterile specimen cups. Because this specimen will be cultured, we don't want to contaminate it with bacteria. So some textbooks say that you should have the patient rinse their mouth with water first, but there's no research that shows that that helps to rinse the mouth with any bacteria or causes any less contamination. So for our purposes, we're not going to even mention rinsing the mouth. So instead, you're just going to follow those instructions, have the patient deep breathe, cough, expectorate the secretions, and then they're going to spit it into the cup. So this sterile specimen cup is not just a regular cup, but it is sterile inside. At the hospital, it usually comes in a little plastic bag, and if you see, there is a sticker. Once you break the sticker, it is no longer sterile. So these cups are more expensive than the non-sterile cups, so you should really only be using these in the hospital when you're sending a sterile specimen, okay? Because sometimes you'll get in trouble if you're using this cup for something else and it's not sterile specimen. Okay, so if you have an alert and oriented patient who can follow directions, then you can actually give the patient the cup and they can keep it with them, and you instruct them to take the top off when they feel like they have to spit out some phlegm, and just instruct them not to touch the inside or the rim of the cup. Spit it in, close it, and that's it. Okay, if a patient has a surgery or something in their abdomen, then you don't want them just coughing, because that could give them pain or open up the wound on their abdomen. So you want them to splint. So you're going to give them a pillow, they hug it, that way they have some support, and then they can cough it up. Next, let's describe how to collect a sputum specimen, but from suction. So just like before, you're going to check the doctor's order. You're going to put the patient in either high or semi-Fowler's position. This time, they probably won't be sitting on the edge of the bed. You'll have them fully in bed. You will want to drape them with a towel because this one can get a little messy sometimes. You may need to give some extra oxygen if they need it. And this one has a special little device that you're going to use, and it's pictured right here on the right hand side. So you have a little special specimen cup with 2 ports. One port is going to the suction and the other port is going to connect to your suction tubing. Okay, so once, and you can see the tubing there in this picture, that little black piece is how you control the suction. So this tube is going to either go down orally or nasally, and you definitely want to lubricate the suction catheter, and you're going to advance it, and this is sterile technique because you are advancing to the trachea. Again, important things to remember: you have a special specimen cup, you're going to use sterile technique, so sterile gloves, you're going to use lubrication, and that little button on this little black piece of the catheter, you want to make sure you control the suction. You're not going to suction on your way down. You're only going to suction on your way out. Okay? Now moving on to manifestations of hypoxia. So hypoxia is low levels of oxygen to our tissues and our organs. So this you should definitely be familiar with, because if you have a patient that has some of these signs and symptoms, then you want to be able to recognize it quickly so that you can give them oxygen. So the early signs: tachypnea, so they're going to be breathing fast; tachycardia, they're going to have a high heart rate; they can be restless, they'd be anxious, even confused; pale skin, mucous membranes will be pale as well. You can have an elevated blood pressure. You'll see the use of accessory muscles, nasal flaring, adventitious lung sounds. That just means not normal lung sounds. So those are all the early manifestations of hypoxia. Later on, they can have stupor, which means they're close to being unconscious, cyanotic skin, bradypnea, bradycardia, hypotension. So everything kind of just slows down, and then their heart can be affected. And this is because the actual heart muscle is being deprived of oxygen, so that is going to show up as cardiac dysrhythmias. So these are the things you want to pay attention to when you're assessing a patient, even a patient that you don't know is having a respiratory problem. If you see any of these early signs, then you definitely want to do something about it. Administering oxygen. Number 1, oxygen is a gas, and that requires a doctor's order. So you want to make sure that that is in place before giving oxygen, of course, unless it is an emergency situation. Now, most hospitals nowadays, when a patient is admitted, they have standing orders, standard admission order set, and it usually includes some type of statement that says, provide supplemental oxygen to keep oxygen saturation above 95% or above 92%. So that kind of gives you an order to work with during the whole admission. You can apply it as you see fit. So you, as a registered nurse, you're responsible for assessing a patient's respiratory function and initiating oxygen therapy, and then monitoring the patient's response to oxygen therapy. And your ongoing assessment should include everything that we just talked about: the respiratory rate, the depth, the rhythm, breath sounds, their color, their capillary refill, and their pulse ox results. Okay, so now we're going to talk about all of the different oxygen delivery systems. So first up is nasal cannula. I think everybody's familiar with a nasal cannula. It's a small flexible tube with two little prongs that you stick into the nares. Now there is a right way and a wrong way to insert them. The prongs actually have a way, they kind of are a little curled. So that curl should actually go down. Okay, that follows the natural anatomy of the nose. Sometimes you'll come into the room and it's actually flipped the other way and the patient is kind of uncomfortable and they don't even know it. So you just kind of need to flip them back over. Okay, so now we're being introduced to how we measure oxygen. So for nasal cannula, we're going to refer to 1 liter, 2 liter, 3 liters, 4, 5, 6 liters per minute. So that's how we're going to document. Now you see this FiO2. So FiO2 is the fraction of inspired oxygen. So what does that mean? So that is the amount of oxygen in the gas that we're in the air that we're breathing at that time. So for example, if you are just breathing room air, we have an FiO2 of 21% because in our atmosphere on planet Earth, our oxygen gas around us is at 21%. So technically, if you're at room air, your FiO2 that you're breathing in is 21%. If you look here, 1 liter is 24%. 2 liters is 28%. So you can see that they're going up in 4% increments per liter. Do you need to memorize that? No, you don't. You just need to understand the concept of what FiO2 means. Okay, so FiO2 means is just the amount of oxygen in the air that we breathe. And room air is 21%. Okay, so back to nasal cannula. So nasal cannulas are nice because they're kind of comfortable. Okay, they don't block your mouth and they're lightweight. You can eat and drink while you have it on. It doesn't interfere with that. And if the patient breathes through their nose, then it works really well. But you will encounter at some point somebody who has a nasal cannula on and they're a mouth breather. So maybe they're okay during the day, but then at night, their mouth is wide open and they're not even breathing in their nose, so their nasal cannula isn't as effective. So in that case, you kind of have to troubleshoot. I've seen sometimes the nurse will just kind of put that nasal cannula in the mouth. That's something you might do in practice. You're not going to see that in a textbook. So just be aware that nasal cannula, comfortable, lightweight, patients can eat and talk. However, it may not work so well with the patient that breathes through their mouth primarily. Before we move on with the rest of the oxygen delivery systems, I want to remind you that anything that you are putting on the body, so a nasal cannula, an IV, a Foley, like an indwelling urinary catheter, an NG tube, anything that's foreign, that is abnormal. It's not something the body normally has. This can lead to skin breakdown, to pressure injuries. So a nasal cannula is no exception. So this little skinny tube can cause pressure injuries around the ears and even in the nares. Sometimes they're really tight. So you as a nurse, when you have a patient with a nasal cannula or any other artificial line, you have to make sure that you're assessing the skin. Okay, so for nasal cannula, this is good for oxygen delivery 1 liter per minute up to 6 liters per minute. So what you need to remember though, if you have a patient that has an order for 4 liters per minute or above, you can use the nasal cannula, but you need to provide humidified air. So over time, all of that oxygen in the nose can really dry the mucous membranes. It can cause pain, discomfort, cracked, and even wounds in the nose because it's so dry. So you don't want that to happen. So you want to make sure you humidify that air. The way you do that is you get a special sterile water bottle, and it actually has a port to hook up to the oxygen on the wall so that when the air passes through the tubing, it becomes humidified. So really simple. You don't need a doctor's order for that. That's something that you can do yourself. Next is a simple face mask shown here in the picture. So this mask covers the nose and the mouth, and it has like an elastic band around it. So this one can accommodate more oxygen flow. So this one, so your textbook says 5 to 10 liters, ATI says 6 to 12. Doesn't matter, just remember that it's more than the nasal cannula. So this one, you can't really talk because you're muffled, and you can't eat with the mask on. Also, you have to have at least 5 liters going or 6 liters going at a time, or else it's not going to be effective. It's not going to have effective oxygen delivery, because when you have the mask on, you're breathing in and out, you're breathing out carbon dioxide, and it's just going to stay in there unless there's enough oxygen force to push it out. That's why there's those little holes there. So you shouldn't ever see a patient with a simple mask on that has like 3 liters a minute, because it's not doing what it's supposed to do. So remember, simple face mask will say 6 to 12 liters per minute. These are temporary, okay? A patient won't be on a simple mask for days because it's uncomfortable, it can cause pressure injuries, it'll dry those mucous membranes, and they can't talk very well, and they can't eat with the mask on. Again, you want to make sure you check under the pressure points where that mask is hitting, and if they do need to have it, on for a day or two, then you want to try to pad under those, under the mask and under the straps. Okay, next up is a partial rebreather mask and a non-rebreather mask. So this one looks like a simple mask, but it has this like rectangular bag connected to it. And you hook it up to oxygen and you turn it on. And for the partial rebreather, you're going to turn it on until the bag half fills with oxygen. With the regular non-breather, you're going to fill up the whole thing with oxygen. Now this is the one that you're going to see on very sick patients because it delivers a high concentration of oxygen. It can actually provide up to 100% of FiO2, 100% FiO2, which is 100% oxygen. So again, this is temporary. You're never going to see a patient for 2 weeks on a non-rebreather, because that means they're not getting better, and they're going to need a longer term solution. So you never want to have a non-rebreather mask on a patient with the bag deflated, because the patient can actually suffocate. There is a valve on this mask that allows the carbon dioxide that's breathed out to exit, and then it's quickly replaced by oxygen. So there's always like that reservoir. So again, really sick patients will have a non-rebreather mask. You use it when the patient needs high levels of oxygen very quickly. Okay. Next we have a Venturi mask. So a Venturi mask looks kind of like a simple mask, but it's hooked up to a little tube, and it has these colorful little valves that you can use. So what the difference is between this and the others is that this one provides a precise amount of oxygen, of FiO2. Very precise. So each one of those little valve colors represents a percentage of FiO2. So if a patient needs 50%, you put that on and it will deliver exactly 50% of oxygen. With this one, the mask needs to be on very, very snugly in order for it to work as it should. And an example of a patient that would benefit from this is like a COPD patient that I mentioned earlier, who their drive to breathe is low levels of oxygen. So if they're in the hospital and they're having some type of infection or whatever exacerbation, and you really want to be careful, then this would actually be an appropriate mask, because it really allows you to control how much oxygen is delivered. Now, why is this important? Well, we don't want to give too much oxygen. One of our goals with any patient who's on oxygen is to taper it down to the least amount of oxygen necessary to maintain their oxygen saturation in their blood. So more is not good. So if you have a patient who is on one of these Venturi masks, you want to continually assess them to make sure that they still need those supplemental oxygen, to see what their actual requirement is. And the way you would do that is, for example, a nasal cannula. Say you have a patient that has been on a nasal cannula for 3 days in the hospital on 3 liters. When you go into the room, what you could do is put the pulse ox on their finger, and choose a time where you're going to be in the room for a little while. So maybe you're going to give medications, and while you're prepping your medications, you can adjust the oxygen on the wall to maybe less than that, maybe 1 liter, 2 liters, and then you see how the patient does. Don't even tell the patient, make the adjustment, recheck their pulse ox, and if they maintain adequate oxygenation, then you can taper it down. So that is something that you should always have in your mind. We want to get them off oxygen completely if possible, or at least the minimum amount that can maintain their oxygen saturation. So that leads us to our next slide, oxygen toxicity. So when you have really high concentrations of oxygen, usually like more than 50% of FiO2 for a long time, and a long time meaning like 1 to 2 days, then it can cause this toxicity. And what you're going to see is a non-productive cough, substernal pain, so that's like right below the sternum, nausea, vomiting, fatigue, dyspnea, restlessness, and paresthesias. So paresthesias is like tingling and numbness in whatever areas, part of the body. So this is definitely something you should be familiar with for your exam, is the signs and symptoms of oxygen toxicity. So say you suspect this, what should you do about it? Like I just mentioned, you should always use the lowest level of oxygen necessary to maintain adequate SpO2, and you should always be assessing that at least a couple times a shift. If the patient is looking like they're tolerating that oxygen, then you can try to decrease it by 1 liter, 2 liter, just depends. So one thing, don't tell the patient you're decreasing it, because sometimes that alone gives patients anxiety. You know, oxygen can be a comfort to some people, and having it on makes them feel better, like they don't want to take it off. And if you start messing with their oxygen levels and say, oh, you don't need it, then it might give them anxiety and make them even short of breath. So you can just taper it, check it, and then, you know, after the fact, be like, oh, hey, you know, you don't need it after all, something like that. Okay. You want to monitor those ABGs, because that is giving you insight on the oxygenated blood, the arterial blood, to see if those acid-base changes have become a problem. Okay, so that can be a good indicator, a good, good diagnostic test to assess for oxygen toxicity. Decrease the FiO2 as the client's SpO2 improves. Again, if you have a patient that was in the like 91, 92%, and you see they're on oxygen, but they're at like 96, 97% now, go ahead and taper it down and see how they do. A lot of times they don't even need the oxygen anymore. Then we have oxygen safety. So a lot of our patients go home on oxygen, or they're chronic oxygen users at home, so we want to make sure they're safe. Oxygen is combustible, so you don't want them smoking around it. You don't want that to be near open flame. We want to make sure that they are plugging in their like oxygen concentration device into a 3-pronged plug. That means it's grounded, so hopefully it doesn't cause any electrical sparks. Of course, we don't want them to use any electrical equipment that is stripped or frayed, no petroleum products, aerosol products, stuff like that, where oxygen is in use. Make sure there are signs in the assisted living that you're going to. You'll see signs on the outside for safety. Patients should also have that in their homes on the outside also. And then oxygen tanks should be stored appropriately. And when patients are discharged with oxygen, especially for the first time, this is something that you'll have to educate them on and go through with them to make sure that they understand, and anybody who lives with them also understands. All right, so that is the last slide. So the takeaway from this module: understand the difference between ventilation and respiration. And remember, respiration is not what we count during vital signs. We're talking about gas exchange with respiration. Understand what our drive to breathe is, okay, and how that differs from maybe a COPD patient. You want to understand things that affect our breathing. So especially like you have a concept map due on pneumonia. With pneumonia, what happens is those alveoli sacs become fluid filled, so they're not able to inflate and deflate appropriately. So if you have a patient with active pneumonia, they are going to have impaired gas exchange automatically, because the nature of pneumonia, it's infection, it has inflammation. We know what inflammation is. That's happening in the lungs. So there's going to be extra fluid. It's going to fill those alveoli sacs, and they're not going to be able to diffuse as well into those capillaries, okay? When it comes to pneumonia interventions, the slides have them: cough and deep breathe, hydration, using the incentive spirometer, positioning of the patient. All of those things are something you can add to your concept map. Make sure you mention specific goals, right? So if they have impaired gas exchange, how do we measure impaired gas exchange? So one of the ways could be an ABG. So you could use that as part of your SMART goal, or it can be as simple as your pulse ox. Pulse oximetry will read, greater than 92% or something like that, whatever your patient is. Okay, so that concludes this module.